Oh, thank you, thank you. I was so glad to hear the lecture because I think any questions? I mean, I've just done the lecture. No, I was asked to quantify the science and forecast the future, and I'll refrain from telling the good old Eskimo story again because most of you have heard it more than once, I guess. But I will just show the two papers that ignited the whole thing with the omega-3. First, our paper 45 years ago. I'm getting older. I learned last night that I'm 60-18 now, which is, I think, is a good, a lady next to me said she was 40-10. I'm 60-18 now, and so it's a long time since. And the other paper came 4 or 5 years later that really ignited the fuse. So I'm now giving the opportunity to summarize as I feel it, the science and look into the future. Doing so, you're always happy to be able to present something brand new. And just before I left, I got the study that I need to present because this is brand new. I got it from my PubMed, weekly survey, and here it comes. Effect of fish oil encapsulates incorporation on the physical, chemical, sensory properties of cookies. Something is going out there. If I've heard about this 45 years ago, I wouldn't have believed that anyone, but okay, that to me illustrates the broadness of the field that we were so privileged to ignite. What I'll do is to focus in for the first half of my speak on health effects of omega-3 acids, which you've heard a lot about. I'll just try to summarize and give my own opinion on heart disease, cognition, mental disorders, vision, inflammatory and allergy, and cancer. And then I'll try to look ahead and look what is to be done and what could be done. And first of it is improvement in study design and technical challenges for the industry. A big job. I'll start with heart diseases. This is one of Adam's slides that I just filled a bit more up, showing a lot of the meta-analysis always coming out with some positive indication of a positive effect. In spite of this, the few rather big, clinical studies that have shown non-effect tend to be quoted far more often presently, for example, by my old friend Paul Nistel in Australia, indications for omega-3 long-chain polyunsaturated fatty acids in prevention and treatment of cardiovascular disease. Omega-3, LC-PUFA, neither beneficial nor adverse effect was demonstrated in primary and secondary prevention of coronary heart disease. And that's the sort of feeling that is out there in spite of all these data. The evidence continues to be positive for the role of omega-3 in the treatment of hypertriglyceridemia and a modest positive benefit in heart failure. Linolenic acid, no effect. That's where we are. So for having the final answer that people will believe in, big clinical studies have to be performed. And I'll just mention what we are waiting for, because there are people out there believing in it because they are putting that amount of money in studies that big clinical studies takes. I mean, it's 2 or 3 million dollars per study. The first one I just mentioned is Reduce It, a double-blind prospective, placebo-controlled study to evaluate the 4 grams per day of ethyl ester EPA for preventing the occurrence of the first major cardiovascular event in high-risk patients with hypertriglyceridemia. 8,000 patients, started November 11, completion anticipated 2017. The next, Strength, randomized, double-blind, placebo-controlled, parallel group enrolling patients with hypertriglyceridemia again, and low HDL with high risk for cardiovascular disease, randomized to either corn oil plus statin or 4 gram omega-3 free fatty acid plus statin for 3 to 5 years, 13,000 patients. Start date 2014, completion date expected September 19. And finally, the vital NCT number, a randomized, double-blind, placebo-controlled 2x2 factorial design study enrolling US adults without cancer or cardiovascular disease at baseline, randomized to vitamin D3 and Omacor, 1 gram per day, vitamin D and omega-3 placebo, vitamin D placebo and Omacor, and both placebo groups. 26,000 persons, started in 2012, expected to be completed by 2018. But people out there are investing in something that is, we have to wait to see. But in the meantime, my feeling is that the data are enough there for using enrichment in the diet of long-chain omega-3 fatty acid in cardiovascular prevention. The next area I'll cover is cognition. In two ends of the life, my end and the other end. Low blood, long-chain omega-3 fatty acids in UK children are associated with poor cognitive performance and behavior. The DOLA study. In 500 school children aged 7 to 9 with below average reading performance concentration of DHA and other omega-3s were low relative to adult cardiovascular health recommendations and dietary related to measurements of cognition and behavior. But even if Susan gave us a good, Susan Carlson, sorry for first name only, but gave us a review of the ongoing studies at her department. This is the latest coming up from the Australian study, the long-chain polyunsaturated fatty acids and cognition in very low birth weight infants at 8 years, which was negative. Long time follow-up of the randomized study. No cognitive or neuroanatomical effects of the supplementation were detected at 8 years of age. But there are still other data. A double-blind crossover design with a 30-day wash-off period between two supplement periods of EPA or DHA. EPA-rich supplementation gave an increase in activation in the right presented gyrus, and DHA had about the same effect and other memory task improvements. Come on. And this preservation of brain volume, which in my age is exceedingly interesting, there are more data on that because the study in Alzheimer dementia showed that in a retrospective cohort study on the relationship between fish oil supplemental use and cognitive decline in 230 normals and 400 patients with mild cognitive impairment and 200 with Alzheimer, fish oil supplement use was associated with a significant lower mean cognitive scale and with less atrophy in one or more brain regions, which gives great hope, at least to me. This has been substantiated in other studies. A higher omega-3 index was correlated with larger total normal brain volume and hippocampal volume in postmenopausal women measured 8 years later. And they concluded while normal aging results in overall brain atrophy, low omega-3 index might signal increased risk of hippocampal atrophy. And then comes the negatives. Effect of omega-3 fatty acids or other nutrient supplementation on cognitive function in the age-related eye disease study 2. Among older persons with AMD, oral supplementation with long-chain proof of, or the other components, had no statistically significant effect on cognitive function. JAMA last year. Mental disorders related to cognition, of course, is another major area of this. And Clemens von Schaage, which has made, I wouldn't say most of the slides I'm going to show, but some of the slides, Clemens, thanks for that, summed it up in one of his presentations that I copied, that low EPA plus DHA levels are associated with postpartum depression, poor brain development in infancy, poor brain development in AD, poor social behavior, emotional lability, depression in adolescents and adults, suicide, poor brain structure, poor cognition, etc., etc., etc. And in one of Clemens' slides, he has just put the suicidal risk towards medium DHA in red blood cells, the omega-3 DHA index or percentage. Putting the US military personnel at the highest end as a reference, and the China group, which has another level and therefore not the same ratio, but 1.0 odds ratio. And you see this tremendous, impressive linear relationship over the area of median DHA in our red blood cells and suicidal risk, which to me is extraordinarily impressive. If we go further on into neuropsychiatric disorders, in British Medical Journal in 2012, Ortega summed up that there were 38 studies at that time examining the influence of omega-3 PUFA supplementation on the prevention and treatment of depression and other disorders. And benefit was noted with respect to treatment of hyperactivity and depression in over half of the studies. But the Cochrane people, who, to my opinion, always find zero results, nearly, summed up in their Cochrane database systemic review in 2015 that at present we do not have sufficient high-quality evidence to determine the effects of long-chain PUFAs as treatment for major depressive disorders. Our primary analysis suggests a small to modest non-clinical beneficial effect of long-chain PUFAs on depressive symptomology compared to placebo. And then, nearly a month ago, there was a study from Japan of cross-sectional association between serum concentration of long-chain PUFA and depressive symptoms in Japan at their high-end level, finding that serum levels of EPA and DHA were inversely associated with depressive symptoms in Japanese community dwellers with higher blood levels of long-chain PUFA. So there is still a lot out there in depressive disorders, but if we go to other more severe, I wouldn't say more severe, but other psychotic disorders, there are data that I just want to share with you that to me are that impressive. First, this study from 2014 in 80 individuals with ultra high risk for psychosis who never had been exposed to antipsychotic medication, erythrocyte membrane level of omega-9s and erucic acid levels were significantly higher, but DHA significantly lower in the cognitive impaired than in the cognitive intact group. In erythrocyte polyunsats in young people with ultra-high risk for psychotic disorders and healthy adolescents, they found that the erythrocyte polyunsats level from 80 individuals showed that PUFA deficits for the ultra-high risk group. Findings provide a rationale for PUFA-based intervention in emerging psychosis. And this has been further substantiated in some studies in schizophrenia. The first one is nearly unbelievable, but I just bring because it fits in with the two next coming. A long-term outcome of the so-called Vienna study giving persons with very high risk of schizophrenia a 12-week course of omega-3 fatty acid supplementation. And their risk in developing schizophrenia were much less likely, 30%, than those who did not get the supplements, 80%, to develop a full-blown psychosis. And then a study by Rice and co-workers, erythrocyte polyunsat levels in young people at ultra-high risk for psychotic disorder and healthy adolescents. Erythrocyte polyunsats level from 80, that's backwards, isn't it? Okay, findings provide a rationale for PUFA-based intervention in American. I think I just had that. Here we go, yeah, you went backwards, yeah. A randomized placebo-controlled clinical trial of omega-3 as a supplemental treatment in schizophrenia. Supplemental omega-3 increases efficiency of conventional antipsychotics in decreasing symptoms of schizophrenia. Low price, rare adverse reactions, and availability of omega-3 made this substance a potential supplement in improved treatment of schizophrenia. And just a week ago or so, a Polish study was published, efficacy of 6 months supplementation with concentrated omega-3 PUFAs in first episode schizophrenia. A 50% improvement in symptom severity was significantly more frequent in the N3 PUFA group than in the placebo group. N3 PUFA may be a valuable add-on therapy able to decrease the intensity of symptoms and improve the level of function in first episode schizophrenia. From this, I switch over to vision, shortly just mentioning Susan Carlson's and co-workers, Berg, of course, study in newborns on mother's milk substitute. Infants fed control formula had significantly pure visual acuity at 12 months of age than any other group getting either 0.3 or 0.5 or 0.9 or 6 or 9% DHA supplementation. In the other end, the AMD, the first findings were that in the women's health study in 40,000 women with the highest third of intake of DHA had a 40% lower risk of H, and for EPA, a 35% lower risk of getting AMD. But oral docosahexaenoic in the prevention of exudative age-related macular degeneration in the nutritional age-related macular degeneration treatment 2 study. 3 years of oral DHA-enriched supplementation had the same effect of incidence of CNV as did placebo. However, and that's essential for what I'm going to end up with, red blood cell fatty acid measurements revealed that CNV incidence was significantly reduced in DHA supplemented patients, showing a steadily high EPA plus DHA index over the years. And that will underline what I'm going to end up with discussing in the design of coming studies. The Cochrane database summed it up. This review found that omega-3 supplementation in people with AMD for periods up to 5 years does not reduce the risk of progression to advanced AMD or the development of moderate to severe visual loss. So again, positive, negative, all over scenery. In the final slide on visual, dry eye syndrome, malfunction of the meibomian gland, there seemed to be an effect that is worth going after in this new study published in Cornea in a randomized double-blind trial in 500 contact lens wearers. The improvement in symptom score was 0.0001 better in the omega-3 group than in the placebo group, and the same was the lens wear comfort levels that improved highly significantly, opening up for an area that has been underway for some years. Next, finally, in this overview, the most essential, as has been underlined very many times during the day, especially also today, is that amongst the many effects of EPA and DHA, the effect on the anti-inflammatory effect may be the most essential. And that is mostly or that is solely or to a large extent based on that in the omega-3 family, the DHA and EPA to a lesser extent gives rise to resolvins, protectins, and myoresins, which do not have any cousins in the omega-6 series. That's a sole omega-3 series anti-inflammatory or resolving components that this family of fatty acids gives rise to. And Sirhan, who has been a major person that in nature gave a survey of this, underlining that the inflammatory process was facilitated towards adaptive immunity, towards wound healing, but by these components and in inhibiting at the same time the chronic inflammatory and organ fibrosis processes. And he summed them up in this slide here in play for some years ago, that these agonists stop polymorph nuclear transmission, stop vascular leakage, hinder cytokine release, and block pain signals, and promote resolution in several different ways. And actually, quite newly came in FASEP a finding of there are new families coming on, 2 novel bioactive families, 17 series sulfide-conjugate display host protective, pro-resolving, and tissue regenerative actions, and they provide mechanistic evidence for the host protective action for the precursor, which is DHA. So new families to the already knowns are coming up, underlining the anti-inflammatory potential, which is illustrated by a study like this one published in Annal of Rheumatic Disorder last year late, an Australian study in fish oil in recent onset rheumatoid arthritis, a randomized, double-blind, controlled trial within algorithm-based drug use, and fish oil supplementation in a rather high dose was associated with benefits additional to those achieved by a combination of disease-modified anti-rheumatic drugs, DMARDs, with methotrexate. These included reduced triple DMARD failure and a higher rate of ACR, American College of Rheumatology, remission, and lowering the need for anti-inflammatory drugs. Finally, before ending up with my comments on the future, I would like to spend a few minutes with the cancer issue, a dangerous issue to go into because, this is cancer. But I would just spend a minute on the ridiculous story of the cancer prostata increasing effect of long-chain omega-3 fatty acids. This, to me, strange study showing a difference of 0.2% in low end of a very low end of EPA and DH content in blood, giving the 0.2% higher group an increased risk, and thereby blaming long-chain polyunsaturated omega-3s for prostatic cancer promoters. Here's a decent study, which by this I mean the other wasn't. Circulating fatty acids and prostatic cancer risk. Prostatic cancer risk by fifth of 14 fatty acids was estimated using multivariable adjusted conditional logistic regression in 5,000 cases and 7,000 control patients from 7 studies with an average follow-up of 5.1 years. There was no strong evidence that circulating fatty acids are important predictors of prostatic cancer risk, full stop. And again, there could be some on the other end because this study is interesting. Prostatic and dietary omega-3 fatty acids and prostate cancer progression in 50 untreated men affected with low-risk prostatic cancer. EPA was associated with a reduced risk of prostatic cancer progression when measured directly in biopsies from the prostatic gland. And they suggest that omega-3 fatty acids, especially EPA, that was what they used. It could just maybe also be DHA, may be protective against prostatic cancer progression. But of course it's maybe, but it's interesting in the light of this study. I'll go to another area of cancers that a dear friend in here maybe have studied with particular interest. Anti-colon cancer activity of omega-3 polyunsaturated fatty acids, EPA, in a phase 2 double-blind, randomized, placebo-controlled trial of 2 grams of free fatty acids, EPA, in patients undergoing liver resection surgery for colorectal cancer liver metastasis. In the first 1 year and a half after resection, the treated individuals obtained overall survival benefit compared with placebo. And they conclude that EPA, FFA may have anti-angiogenic properties, which we know of, remarkably limited to preoperative treatment, and may provide, this was fast, could you go by? Yeah. Yeah. No, you go far back. Yeah, here we are. And overall, all survival benefits. And the final cancer slide is this impressive study published in British Medical Journal some years ago, intake of fish and marine N3 polyunsat and the risk of breast cancer. Meta-analysis of data from 21 independent prospective cohort studies. I mean, these are some numbers, 21,000 cases of breast cancer and nearly 1 million controls. High consumption of dietary marine N3 purifier were found to be associated with a lower risk of breast cancer of 14%. Rather impressive data, to my opinion, at least not indicating any risk, cancer risk, that this was printed, that was mentioned in all newspapers after the prostatic cancer study. And by this, I have ended the first half, no, I'll give some other 10 minutes, to look at, to my opinion, what lies ahead. First of all, improvement of study design. Then the technical challenges for the industry. Clinical trials, therapy versus correction of deficiency. Omega-3 supplements in randomized clinical trials have mainly been used as therapeutic agents and not as supplements to deficiency. The example is that they found that the beneficial effect of vitamin B treatment on brain atrophy was observed only in subjects with high plasma omega-3 level. The results highlight the importance of identifying subgroups likely to benefit in clinical trials. And if you're dealing with insufficiency, you should find insufficient people to deal with. My friend Clemens, thanks again, Clemens, summed that up in PLEFA last year, saying that trial participants are recruited irrespectively of baseline status of EPA, an important predictor of events, as we have seen. Level of EPA and DHA have a broad distribution, together with a large inter-individual variability on response to increased intake. This creates a large overlap of EPA and DHA levels between intervention and control groups. And then again, another aspect, trial participants have been asked to take EPA, many of them together with breakfast, which often is a low-fat meal, resulting in poor bioavailability. So, as he says, there's an urgent need for new intervention trials in cardiology and other areas for which participants with a low baseline omega-3 value are recruited and then treated with an individually tailored dose of EPA to a pre-specified target range. Here is Clemens' data on omega-3 index in the free living population, 110,000 persons, no, 10,000 persons, not 110, 10,000 persons, with a range of 1.9 to 20.7. That's a huge range, so if you just volunteer from this, you get both ends of this scale. And if you then give them something without knowing how they respond, you see the response rate of a single dose of 0.5 EPA daily for 8 weeks. The mean increased, of course, but the variability in response factor was 13. This guy or girl went up that. This person here went up that. And the other one went even down. I mean, okay. A great individual variability. And then there is the bioavailability. We published some years ago a study showing that just giving it to people, take these capsules for, I think it was 8 weeks, ended up with a difference in bioavailability over ethyl ester versus triglycerides, which could have been eliminated by saying, take them together with a fat-rich meal, like this study I also got from Clemens, last slide of yours, showing that giving ethyl ester together with a fat-free or fat-rich meal gave a factor 13 again difference in bioavailability. That really means something. So we need to adjust the studies in that this gives, of course, a great issue of blinding. If you want to go to pre-specified levels, then you cannot follow and then still blind but it is possible to drive around these corners, but it's not that easy. And it leaves me with my last 5 minutes or so to deal with what I think there are of technical issues for the industry. First, as we heard also in the previous discussion this morning, US adults, for example, they are the lowest, are not meeting recommended levels for fish and omega-3 fatty acid intake. In the enhanced examination survey, intake from foods and for EPA and DHA was about 80 milligram per day in total. And they concluded, as omega-3 fatty acids are deemed important from authoritative bodies, supplementation in addition to food sources may be needed to consider to help US adults meet recommendations. And that's the intake. And if you see the results, quite recently, Murphy, who lectured here today, found that overall 80% of participants had fasting plasma long-chain omega-3 below recommended for cardiovascular health, and nearly all had levels below concentration associated with cardiovascular protection. And these findings, as you said, highlight the need to increase long-chain N3 intake among Americans and also among others. But as Salem published last year, do we have enough of the stuff? A recommendation for a daily individual consumption of 0.5 gram of EPA plus DHA would provide health benefits, and this translates to an annual human consumption of 1.3 million metric tons. That's a lot. Fish and vegetable oil will not be adequate to meet future needs, but algal oil and terrestrial plants modified genetically to produce these two fatty acids could provide for the increased world demand. My feeling is that the industry, but now I'm really on deep water, but my feeling that what the industry should do in that area is to start by extraction from marine sources with level lower than those they use nowadays. I think it's always about 20-some percentage, 25 or 4, I don't know. But why not go deeper down and extract it for sources that have lower content? Then there are the calamari and the krill. There could be sustainability issues associated to components like these and also to the other, of course. But these are at least new sources that we're dealing with. But then comes the microalgae grown in agriculture, marine zooplankton, Calanus finmarchicus, bacterial, There are terrestrial that can be used, mix of bacteria. There are marine, Shevanella. I don't know a thing about any of them, but I've read the papers, and they are available and could be used in that way. And I mean, many drugs by the pharmaceutical companies are produced, or very many drugs are produced in tanks using bacteria and cells of whatever source for that. And then there, of course, is the GMO terrestrial plants. So that's what I think is the industry technical challenges. I end up with two slides. This one might not be the true value of anything. I learned from Adam that maybe these data are not correct. I don't care, but these are big numbers, blockbuster numbers. And if you are in a business that provide blockbuster things that goes for inflammatory disorders, heart disease, dental disorders, you name it. I mean, brain disorders. Then there's someone who will invite you this amount of money. Of course, they'll even be sort of enemies. And that could make them funnel negative impact on the omega-3 situation, which I have the feeling that is going on. I'm not pointing on anyone I don't know a thing about. I just have the feeling that, of course, if I was in business, I would say, hey, they're getting too big, they're taking our market share, why not, couldn't we, I've seen some bad data, couldn't we assist and have them in the New York Times and whatever? I don't know, but I would have done maybe the same. So, I think there's something there. And what could you do about that? Yeah, what I think you could do was to focus a bit more on what I said, the insufficiency, dealing with the deficiency states of the thing. Because treating symptoms of deficiency costs money, but treating deficiency might save money. I mean, if you have symptoms because of the lack of a component, for example, DHA, and you treat the symptoms with aspirin, yeah, that's cost you money or whatever it is. But if you're treating the deficiency, you could save money. And these studies are very, very, very rare. I do not know of any but this one. There was, of course, this morning a presentation of what you could do otherwise along these lines. But I think you should focus in on trying to support studies like this one from I think it was from the low birth weight study in Australia. Inpatient hospital cost could decrease by Australian dollar 92 per singleton pregnancy when DHA supplements was consumed during pregnancy. Cost savings to Australian hospital system could be between 15 and 50 million a year. Given that a simple intervention like DHA fish oil supplementation could generate savings to the public, it may be worthwhile from a policy perspective to encourage DHA supplementation among pregnant women. And this is a tiny fraction of the spectrum of diseases where deficiency could be addressed, and things like that could be studied and published, and the public would love you, and the government would love you, and what else can you want? So I highly recommend that this single study, the only one I know of, could be the basis for studies along these lines, helping to maybe turn the waves a bit from something that has had a sort of a rather misty destiny during the last years. Thank you for your attention. I made it. It's 10 to.
Yeah,
it should be. Yeah.
I think we have a moment for one or two questions in the interest of keeping this on track. So if anybody has any questions for Dr. Dyerberg?
I haven't.
You have?
I haven't.
You haven't. Good.
Okay.
Thanks for a very informative presentation. I just have one question.
Yeah.
How much omega-3 do you take? I take it you take it. How much do you take per day and when?
And when? I take it with my afternoon meal. First of all, I eat fish all the time. And as a professional nutrition, point one, add fish to your diet, sure. I mean, I'm a Dane and I love herring and mackerel and nowadays salmon. But then, of course, I take supplements. One of the main reasons is that I get them for free. And I take 2 grams per day along with the evening meal. I haven't ever had my omega-3 index checked, but I might have it for free too. Yeah.
And in what form?
Sorry?
The form?
In capsules, 1 gram capsules. Sorry, yeah. Re-esterified triglycerides, yeah, sure. Yeah, that was drugs we used for the EVT study published last year. That's what I take, yeah. And I'm, as I said, 60-18. Still going. Still going.
Anybody else?
I can't see a thing.
I don't either.
Thank you very much for your presentation. It's always great to hear you speak. I'm Melody Harwood from Neptune. I think that one of the biggest challenges that our industry seems to be facing is the fact that, at least from a regulatory perspective and an authoritative body, scientific body perspective, EPA and DHA are not considered essential. And that's driving a lot of the challenges in terms of getting a recommended intake and getting recommendations for pregnant women and across the globe. So, we've talked at GOED within the board members and some of the committees about starting this discussion again with scientists and academia and the government bodies to maybe take another look at the essentiality of EPA and DHA. So how would you start that conversation, and what recommendations do you have for us as an industry to try to get this moving along?
I don't quite know whether I understood you quite, but first, one of the things was, are EPA and DHA, to my opinion, essential fatty acids? Yes, they are, to my opinion. I know that by definition, the essential fatty acid is alpha-linolenic, and you heard Art Spector talk about that. Thank you, Art, for a gorgeous presentation. By definition, but the conversion rate is that low to EPA and close to 0 in normal living. Well, I don't know what normal living is, but in general, in the general population of Western diet people, you cannot improve your DHA concentration in any compartment in your body by eating alpha-linolenic acid. You can increase your EPA a bit, but both of them are essential, and the interconversion isn't that big either. From EPA up to DHA and down, they are not that big, so you have to have them both. So for me, as a nutritionist, a professor in nutrition, they are essential fatty acids, but this definition doesn't go with the general one, because that's alpha-linolenic acid, which you do not deposit and which you do not know any physiological function for. Anyone in here who knows any physiological function for alpha-linolenic acid? Never heard of any, except for making linoleum. And they're good in some oils and so on. Whereas linoleic acid has some functional, physiological, essential function in skin, permeability, and several things like that. The only thing we know of physiological essentiality is for EPA and DHA, and maybe DPA. We don't know a lot of DPA, but if you take the two, it'll be there along with them. I don't know whether I answered your question, but I answered some of it at least. Yeah. Okay.
I think that's about all we have time for, so
thank you.
Another round of applause.